Disseminated intravascular coagulation (DIC) is a clinical pathological syndrome which complicates a range of illnesses. It is characterized by systemic activation of pathways leading to generation of fibrin clots that may cause organ failure, together with consumption of platelets and coagulation factors that may result in clinical bleeding. The diagnosis of disseminated intravascular coagulation should encompass both clinical and laboratory information. This slide shows the simplified pathophysiology of DIC, where the underlying disorder drives the systemic activation of coagulation and consumption of coagulation factors. Cytokines such as TNF-alpha, interleukin-1, and interleukin-6 mediate the coagulation activation and downregulation of fibrinolysis, causing microvascular thrombosis. On the other hand, consumption coagulopathy increases the risk of bleeding. DIC never occurs in isolation, but is a complication of an underlying disease. Recognizing that an underlying disease may cause DIC is the key to appropriate investigations and management. Shown here are the common causes associated with DIC. Patients with DIC may be asymptomatic with no thrombosis or bleeding, but only with laboratory evidence of DIC. The manifestation of DIC can be acute or chronic. In acute DIC, usually the DIC is obvious and patients have more bleeding complications, whereas in the chronic DIC, patients usually have thrombotic complications. Patients who have been diagnosed with DIC should prompt further investigation for the underlying cause of the DIC. It is important to recognize the presence of DIC because this can cause significant morbidity due to bleeding and also multi-organ failure. DIC predicts poorer outcome in patients with sepsis and traumatic bleeding. None of the available laboratory tests can establish or rule out the diagnosis of DIC. Thus, it is of utmost importance to assess the whole clinical picture, taking into account the clinical condition of patient, the diagnosis, and all available laboratory results. The diagnosis should be based on appropriate clinical setting supported by laboratory results. Investigation for DIC can be done by simple and readily available tests such as full blood count, PT and APTT. The platelet count in DIC is usually low with prolonged PT and APTT. Blood film may show few fragmented cells indicating intravascular microangiopathic hemolysis. The fibrinogen is low in DIC but may be in normal range if the DIC is early. Fibrin degradation products and the soluble fibrin monomer may be raised. This slide shows the scoring system for DIC by the International Society of Thrombosis and Hemostasis. The scoring system considers multiple laboratory results to assist in the diagnosis of overt DIC. However, if clinical suspicion of DIC is high, this laboratory test should be repeated 1 to 2 days later. Differential diagnosis of DIC, such as hepatic failure, can cause bleeding tendency. Dilution of coagulation factors via transfusion is another possible iatrogenic cause in traumatic patients. The most important treatment of DIC is to treat the underlying cause of the DIC. At the same time, we need to support the patient with blood product transfusion as needed. We should not transfuse the patient unnecessarily just based on coagulation profile. Transfusion support with plasma concentrate or platelet should only be given for patients having bleeding or deemed at high risk of bleeding based on clinical judgment. In patients with DIC, if there is active bleeding, significant bleeding risk factors, or invasive procedure is planned, we will transfuse the platelet and the FFP accordingly. Cryoprecipitate is a good source of fibrinogen for replacement of fibrinogen if needed. Few of the important messages for DIC are shown in this slide. Early recognition, appropriate investigation, and early intervention are the key to successful treatment of patients with DIC.